Okay, thank you, JIX committee, for giving me opportunity, and I congratulate JIX for conducting such a wonderful conference. Till now, we spoke about which antibiotic, what is the combination. I'm going to talk on early initiation of antibiotics on patient outcomes in gram-negative sepsis. Early means how early? Current global estimates 49 million cases of sepsis occur annually worldwide with about 11 million deaths. Big number. Administration of appropriate antibiotics is a cornerstone of sepsis, but there is a considerable controversy time to antibiotic therapy. This is published recently in Lancet 2020. So if you look at the recent study, EPIC-3 study, there is a 67% of the patient have gram-negative pathogens. So in these studies, what I'm going to quote, most of the studies related to gram-negative sepsis. If we go back to 1997, Luna et al., who showed us when antibiotic therapy is initiated early, mortality is reduced if this antibiotic therapy is adequate. One step ahead, even though adequate or appropriate antibiotic therapy you want to give, if it is given later part of the disease or sepsis, it doesn't improve mortality, so it doesn't serve the purpose. So here comes the timing. How early to be given? So Kumar in 2006 clearly showed, it's a retrospective study, survival rate dropped an average of 7.6% for each hour of antimicrobial delay after the hypotension. Means each time for the shock, their timing starts. So this is the very good study, but all these studies are retrospective studies. As I mentioned, most of the studies, all these studies involved gram-negative sepsis. In 2014, Ferrer, he involved both severe sepsis as well as septic shock. Almost around 18,000 patients in 165 intensive care units found an hourly increase in mortality following recognition of severe sepsis, not just onset of hypotension. It means both sepsis as well as septic shock, there is increase in mortality. If you see here, up to 5 hours, even though there is a increasing hours, there is no significant increase in mortality till 5 hours. After 5 hours, there is a clinically significant mortality is there. He notices this. He mentions beyond 2 hours, there is a differences were statistically significant only beyond 2 hours. So Seymour almost he took around 50,000 patients, is mandated to protocolize and track sepsis, including bundle of care to be completed within 3 hours sepsis. He also showed the strong relationship with the time to antibiotic therapy. He adjusted for sex, vasopressor use, admission, source, gram-negative sepsis. In his study, he mentions crude mortality rate were similar for the first 5 hours until antibiotics and rapidly increases thereafter. So he found there is increase in mortality in septic shock patients who require vasopressors compared to not requiring vasopressors. But he mentions about the timing up to 5 hours, there is no significant increase in mortality. Liu et al., he took around 35,000 patients, all retrospective study. He also mentioned septic shocks kills more. But if you look at here, from 2 to 5 hours, there is, stable increase in mortality with the delays 1 to 5 hours and large increase with the delays only after 5 hours. Means all these studies mentions up to 5 hours, it is okay, we can take a time in case the patient is not in shock. So if we involve all the studies, almost there are 30 published studies are there. There are 3 meta-analyses. If you know all the meta-analysis, there is big confusion. This meta-analysis, Sterling in 2015 found no significant mortality benefit of administering antibiotic within 3 hours of ED triage or within 1 hour of septic shock. So this create problem for us. Where went wrong? The critical analysis, if you see here, in these studies, 40% of the patient admitted to ICU with working diagnosis of sepsis turn out to be non-infectious. Maybe we are treating patient non-infectious with antibiotics, Aggressive time to antibody targets risk promoting antibody overuse and the potential risk for antibiotics. So it can cause resistance, allergy, hypersensitivity reaction, kidney injury, thrombocytopenia, and clostridium difficile infection. Maybe increase in mortality with respect to resistance. So we are doing something wrong here. So another problem here is we are pressured, clinicians can be pressured to taking shortcuts in their evaluation because overly tightly time to treat targets. Within 1 hour you have to give antibiotics. Clinician may be pressurized to give antibiotic, then start he may not he may not identify even the non-infectious cause also. May also lead to delay in identifying and treating non-infectious sources of instability that could be further harmful to the patient. He may not identify pulmonary embolism, many other non-infectious cause which may cause harm. So where we went wrong here, sources of potential bias in studies, there is a illness severity in all studies, if you study only severe sepsis patient, they will look differently versus septic shock. The another important is linearizing the non-linear outcome. This is very important. Hour by hour, mortality rate is a nuisance pattern. So we should not be so serious. I feel hour by hour mortality rates tends to be flat for first 3 to 5 hours. Only thereafter it is rise clearly and persistently. This patient I'm talking about without septic shock. Controlling for confounding non-infectious or infectious as explained. Timing zero, that is very important in practice. No time zero is perfect in representing a clinically meaningful time point because patients seek medical care at different points in their illness. This is again problem. So we have a 2 randomized control study. One is MEDUSA study, a multifaceted educational intervention for anti-infectious measures on sepsis mortality involving 4,183 patients. What they implemented is they educated sepsis education and quality intervention in 40 German hospitals and compared this to standard continuing medical education. In spite of teaching, nursing staffs, doctors, unfortunately, they found no difference in mortality, no difference in median time to antibiotic delivery, that is 1.5 to 2 hours, in spite of teaching this. And even though mortality is high in the intervention group, that is high disease, high critical illness in those patients, that we cannot consider here. Study does not add any information regarding the optimal time to antibiotic therapy, but it clearly highlights the practical difficulty hospital face with administering antibiotic within very short intervals. Within 1 hour, very difficult. As shock, definitely we can give, but in other patients, it may be a difficulty, administer antibiotics. Differences in patient outcome may be related to higher disease severity. There are another randomized control trial. This study mentions giving antibiotic in ambulance itself. So pre-hospital antibiotics, it is in the ambulance, a multi-center open-label randomized trial, 2,600 patients, training pre-hospital EMS to identify patients with signs and symptoms of sepsis and administering ceftriaxone. Patient administered with the pre-hospital antibiotic receive antibiotics 96 minutes earlier than conventional treatment. This study also mentions there is no difference in outcome. So in fact, in spite of the 90 minutes earlier if you give antibiotic, that doesn't make outcome. Again, these patients are not with septic shock. Later they found only the, sepsis patient. Thus, study provide a good evidence against 1 hour treatment goal for sepsis without shock. At least we can, one randomized control trial come forward. Sepsis without shock, it is not, we cannot do antibiotic immediately within 1 hour. Interval up to 90 minutes we can take. So if you look at all these studies, if you have to make a framework for timing and broadness of antimicrobials, see, shock, lactic acidosis, altermentation, respiratory failure, yes, we have to give straight away antibiotics, at least with equivocal evidence of infection. Rapid diagnostics to confirm or rule out infection is very important. We can use ultrasound, respiratory virus setting, urine analysis, biomarkers, PCR-based blood and sputum studies. At least we have to differentiate within this time. So 2021 Survive Sepsis Guidelines clearly mentions sepsis is definite or probable and shock is there, we can give immediately antibiotic within 1 hour. There is no controversy here. If sepsis is possible, then also we can give antibiotic, there is no need to wait. If you think sepsis, infectious versus non-infectious, then at least we can take time, at least 3 hours to rule out whether infection or non-infectious. So this is Aptagelim avibactam has come into our one more, this thanks to Pfizer here. Most important here is not to get the outcome, antimicrobial stewardship is also very important to improve our outcome. So what the message is from these, there is no argument that timely administration of antibiotics in septic patient is crucial to improving outcomes in gram-negative sepsis. We have to give timely antibiotics. There is no argument. How early, that is the key point here. Immediate antibiotics, ideally within 1 hour if the patient is septic shock. Interval more than 5 hours are clearly and consistently associated with higher mortality rates in sepsis without shock. In these cases, if the diagnosis of infection is very likely, then there is no reason to delay antibiotics. We can go ahead with antibiotics. If there is uncertainty, time-limited course of aggressive investigation and treatment of possible non-infectious causes is warranted, and it is a safe practice. So we can take time up to 3 to 5 hours. If these investigation and treatment fail to rule out infection, then antibiotics should be given no later than 3 to 5 hours. If rapid investigation establishes a non-infectious cause, then antibiotics can likely be deferred. So thank you.